Welcome to Healthcare Blind Spots. I'm Vivian Kopsinje-Bertrell, your host, and my special guest is Dr. Fleury Nsole Biteghe. He's originally from Gabon, but he's a professor here at Northeastern University, and we'll be talking about precision medicine. Welcome, doctor.
Thank you very much, Vivian.
Good to have you here.
It's good to have you. Thank you for hosting me in your TV.
It's such an honor. And today we will be talking about precision medicine. But before we get there, tell us a little bit about yourself, where you come from, and how you got into the profession that you are in.
Okay. So as Vivian mentioned, thank you again. I am originally from Gabon. So I was born in Gabon, which is West Central Africa. So to just give a summary on my journey, so I did my high school, up to my high school in Gabon, and usually when we finish high school, we get to have scholarships. So Gabon's government provides scholarship for students to go overseas. And for me, I wanted to be a genetic engineer, right? When I left Gabon, because when I was in high school, I was so passionate about genetic engineering, and I said, like, this is what I'm going to study. So I was given a scholarship to go and study in South Africa, where I did all my tertiary educations. So I did my undergrad at the University of Western Cape, where I graduated with a bachelor in biotechnology. However, biotechnology is a very big field because, as you can think, biotechnology applies to the food industry, to environmentals and medicals. But I was more turned toward the medical aspect of it because of I've experienced people suffering from non-communicable diseases, such as sickle cell anemia around me. And I was very interested by the genetic aspect of it. And I was telling myself, like, can I fix that by specializing in genetic engineering? So once I got my bachelor degree at University of the Western Cape, that's when I decided to leave because there was no medical biotechnology there. So I switched to the University of Cape Town, and that's where I started working on cancer and specializing in cancer-related research in addressing precision medicine.
And which is a great segue into precision medicine itself. What is that?
So precision medicine, in order to explain that, I first want to explain what's the standard care in terms of, let's say, I will take as an example, cancer. So what happens usually when people get cancer is, first of all, the people go into the hospitals, and for example, for breast cancer, they go and have a mammography, which is like a kind of like an X-ray of the breast. And depending on how the tissue looks, the doctor can ask the patient to say, like, we need to collect a biopsy. And the biopsy is just like a tissue that is suspected to be carcinogenic, right? So when the patient gets it, he usually goes and sends it to the hospitals, to the pathologist, who is the specialist who will analyze the tissues. And at the end of that, the aim of the pathologist is not only to determine whether or not the patient has cancer, but it's also to determine what stage of cancer it is, right? So in cancer staging, we have what we call benign. Benign means it's still on the breast. In the case of breast cancer, it's still on the original tissues. It hasn't left the breast to another organs. Or it can be metastatic. That's when it leaves the primary tumors and goes into the distant tissue, right? So once the doctor receives that feedback from the patients, usually they first get referred with chemotherapy or radiotherapy. So it's important to kind of decipher between local therapy and systemic therapy. So local therapy is like, think of X-ray radiotherapy. It's just they irradiate the targeted tissues. So it doesn't go everywhere in the body, right? This is usually used for treatment of the benign tumors. Alternatively, they can have what they call mastectomy, is a removal of the breast, complete removal of the breast, right? So this is what is mostly offered in low and middle income countries and even in developed countries for tumor that haven't metastasized.
Right.
The problem comes now when the tissue leaves the primary, the breast, and goes in distant organs. And that's become a problem because now it goes into the blood vessels, and the blood vessels, and that becomes an issue because it can land in the brain, it can land in the liver, and that can be life-threatening.
Right.
What has been the standard of care for the past decades, it was chemotherapy. But the problem with chemotherapy, you have to think about it. The cancer is cells that divide uncontrollably. Right? And whenever we give chemo is supposed to target a cells that reproduce rapidly. But the thing that is very important is chemotherapy sometimes does not distinguish between healthy cells and the cancer cells. And when I say healthy cells, I like to take the example of the epithelial cells, which are the cells of the hair, right? I had just had my hair cut like 2 weeks ago, and then my hair are back, right? So what we observe mostly clinically is people, whenever they have chemotherapy, they lose the hair for the very simple reason that the chemotherapy goes and accumulates into healthy tissue and not necessarily optimally into the targeted tissues.
Right.
Now, doctors were thinking of a way of how do we minimize the damage on the healthy tissue and then maximize the toxicity on the targeted cancer cells.
Right.
And that's why precision medicine came in. So precision medicine is like, it's a science whereby one wants to be able to identify and deliver the drug selectively to a specific targeted cells, right? An examples of precision medicine will be that loading that drug with a zip code and telling that drug the cancer zip code is 0111 only goes and accumulates into 0111. That's what precision medicine will be.
Right.
In simple words, yeah.
Well, it's amazing that you're talking about the drug itself being targeted, because I've had previous conversation with the tiny drones where it's the mechanism for delivering the drug. And what you're talking about is the drug itself targeting the cancerous cells. And so in terms of your focus, what drove you to decide to focus on this precision medicine? We discussed the trends of cancer, and you have been talking earlier on, and you have been talking about breast cancer, which is one of the, one of the cancers that is predominant in certain parts of the world, including Gabon, Uganda. So can you maybe just take us through the trends of those cancers and why you chose to focus on precision medicine?
Okay. Thank you, Vivian, for that question. So the first reason I chose the breast cancer and the cervical cancer are for one reason is, first of all, the breast cancer is the first cancer affecting women. Okay? And if you have to go into sub-Saharan country and most low and middle income countries, cervical cancer is the second cancer that has been associated with the highest incidence and the highest mortality. So for me, the breast and the cervicals and the cervix are very two critical organs. We need women to perpetuate life, right? So if the uterus and the cervix are not working well, there is no way human can continue reproducing. The second thing is the breast is what feeds the babies. And in order to grow, we need a healthy breast. And studies have shown even like when women don't breastfeed, it predisposes them to develop cancer, and that has been shown in Europe. So these were the first two reasons of why I first focused on these two specific cancers in my research. Now, why I was interested, because precision medicine is almost not accessible to low and middle income countries, because most of the studies that are done are performed on Caucasian populations or Southeast Asia, Japan and China and all these developed countries. When we looked at the comparison to African countries, almost none of them have access to precision medicines. I even had friends in South Africa who got diagnosed with cancer and who had to fly outside the country to receive precision medicine treatment, either in coming into the US. So based on that lack of resources on the African continent to provide precision medicine, in 2015, the South African government developed what they call a program, a SARCHI, where they will call world experts in specific field to kind of develop precision medicine. Why precision medicine? Is because also precision medicine has shown to have better therapeutic results compared to standard of care, chemotherapy and radiotherapy, right? And it has to have shown also a better quality of life for patients compared to standard therapy, right? So that's why I mostly kind of joined precision medicine, because I was like, can we have better therapeutic results with less toxicity on normal cells? And yeah, that is one of the reasons.
And since you mentioned, the breast cancer and the clinical trials, for lack of a better word, being done mostly on Caucasian women, can you take us through the differences in some of the research you found or research that you've been a part of where you've determined different biomarkers for breasts among African women?
Okay. First of all, there is a field called pharmacogenetics. Pharmacogenetics is a field that is trying to develop drugs based on people's genetic background. And as we all know, the highest diversity is observed in African populations because that englobe almost like part of the world's biggest biogenetic diversity. There is a professor at the University of Chicago known as Professor Olufemi Olopade who did a great study. In 2017, they had the first American Association for Cancer Research meeting in Cape Town, and I was very interested by her research. She looked at people of African descent genetic variations in triple-negative breast cancer. So what she did, she took people from a tribe in Nigeria called the Yoruba people. She took a Yoruba people born and raised in Nigeria, living in Nigeria, and she took a very same population of Yoruba people born and raised in the United States of America. And she looked at the difference in the genetic determinants between these two populations living in two different geographical locations. What was very interesting is she saw completely distinguished biomarkers. Let's say one had a BRCA1 mutations, this one will have a completely different mutations. So the mutation profile, because what will have been drawn if the study was only done in Nigeria, people will have said BRCA1 mutation is specific to the Yoruba population, right? But what a study was telling that BRCA1 mutation was a reality only for the Yoruba population living in Nigeria. Awesome. You understand? So
yes.
Now, what has been shown is triple-negative breast cancer has been more aggressive towards African women compared to Caucasian populations. And most of the research, for example, has been done on Caucasians. And what you have observed, they have different completely biomarkers. An example is epidermal growth factor receptors, which is overexpressed. But we don't have like a solid profile on African descent patients that are suffering from this specific disease. And because we don't have this profile, therefore, we cannot implement precision medicine treatment because the prerequisite for someone to benefit from precision medicine drug, we first have to know which marker that patient is expressing. And by marker, I mean like which type of protein. It's almost like when people look for a pregnancy test, right? Yep. You have the positive and negative results. We want to know what is the patient positive for. And if what the patient is positive for is available clinically, then we say the patient is going to take molecule A because for molecule A, there is a treatment that is clinically approved. But currently, there is a discrepancy in terms of what is the profile of African patients, and that's what we are trying to address right now.
Yeah, and the reason I asked is, for first of all, me being Ugandan diaspora, I'm living in the United States, but from what I have been hearing is that different factors might change the genetics.
Okay.
And is that something that you have seen for other cancers, not necessarily breast cancer? And what should we be looking out for as patients, or no, not patients, as users of this healthcare system that has so many disparities in terms of treatments? Okay.
So I think what is important, and coming to the study that I was explaining, it's address the effect of epigenetics. There is what we call epigenetics. What is epigenetic? Is the capacity to have some gene expressed at a certain moment of life and not getting expressed. I will take an example. When someone is a baby, for example, right, he doesn't have a beard. So the genes that are responsible for the expression of the beard are off. It's only when you reach a certain age, like 16, you get to 16, you start expressing it, right?
Right.
So that's the same principles. Another example is the melanin pigments. The melanin pigments, when we go into the sun, we produce melanin. But what people don't know is we don't produce melanin because of the color. Because what melanin does, it goes and sits around the cell nucleus where you have the DNA to protect the DNA from UV. Now think about it. If someone is living in the developed country, where, for example, the US, we know that we have many months, we have winter. We are more indoor than outdoor. What does it mean? The body will readjust because we're less exposed to the sun. So the person will tend to less express that specific gene because he's not getting exposed to as much sun compared to the summer season.
Yep.
So the same principle is really true for breast cancer, because breast cancer and any other cancer is the heterogeneity that makes it difficult to treat. because it will express certain biomarkers, and after treatment, it may adapt.
Right.
It will say like, I have received a specific chemotherapeutic drug, let me switch off this gene and starting express other genes. So what clinically people should be looking at is, first of all, having the profile of the genes and the biomarker that I express, and even post-treatment in patient that relapse, what is the profile of the patient that relapse? What type of genes are they kind of activating before relapsing? Because once we have this information, then we better know like, okay, this is what needs to be done for us to kind of adjust and to decide whether the patient will receive combination treatment to kind of improve the treatment. Yeah.
Absolutely. And which brings me to another question about, you mentioned sunlight.
Yeah.
And previously we were talking about some therapy or intervention.
Yep. Photodynamic therapy.
Yeah. Can you tell us about that therapy? And then we'll take it from there, because I have some other follow-up questions.
Okay.
Yeah.
So I started my cancer research working on photodynamic therapy. I was very interested by that because that was the first time for me to hear that.
Yeah.
And then what is photodynamic therapy? It's a light-based therapy where you have a light-sensitive compound, such as turmeric. Turmeric is, for example, a photosensitizer. It's sensitive to light. And when you expose turmeric to light, it produces bomb-like oxygen species. So just thinking like you have turmeric in water, you put the light, and it creates a bomb, right? But that bomb is at a very cellular level, right? And that bomb is enough to kill the cancer cells, because when it kills when it's kind of damage the DNA, it activates mechanism that requests the cell to be destroyed.
Right.
So that's what photodynamic therapy is. So photodynamic therapy was created like 5,000 years ago back in Egypt. That's the origin of the photodynamic therapy, and it's been used in clinic for treating superficial cancer, like the cancer of pancreas. I know it's also been approved for lung cancer using certain type of chemotherapeutic drugs. The benefit of using this type of therapy is because this type of therapy have got a second layer of control, because if you don't shine light on the patients, it won't activate the drug.
Right.
It only gets activated by shining light on the specific tumor tissues. So now, why is it important? Because as I mentioned, if you give chemotherapy is just killing everything. So using photodynamic therapy is you shine the light, it only kills the region that is being irradiated, and by this you minimize again the side effects. But there is a limitation to that, because as I say, the drug is sensitive to light.
Right.
And because it's sensitive to light, the patient has to make sure that the drug gets out of the system completely before going out of the hospitals. Because if it gets out in the sun, it can still activate the drug, and it can also lead to damage of healthy tissues. And that's what they call photosensitivity, right? When patient goes out. So there is pharmacokinetics. And what is pharmacokinetics essentially is whenever a patient takes drug, how long does it take to get out of the system?
Right.
Right? So this type of data needs to be evaluated beforehand, so that we know like if the patient takes the drugs, how does the gate go out of the system? Sometimes it's to the urines or the livers.
Right.
And then if we know, for example, the patient, it takes 5 days to take the drug out, then the patient will be kept in the hospital for 5 days, because after these days now, that's where the patient can go out and then can now not be having the risk of being exposed to this light therapy. Yeah.
Yeah. Can you explain maybe how, I don't know whether it was a similar therapy that was addressing the lesions on cervical cancer?
Oh, yeah. It was photodynamic therapy. So why is photodynamic more beneficial? Because the way a cervical cancer is treated, sometimes they can have a surgery, right? And the surgery is not conserving the tissue of the patients, and it's very damaging to the cervical or whatever the therapy it is. Even the head and neck cancer, the patient can have surgery, and the surgery are very damaging. But by using photodynamic therapy, it has been shown that we can have equally good data and with more conservation of the tissue that will not necessitate any surgical interventions. But the very interesting thing about that is there are some group in Brazil, for example, they have developed portable lasers. So portable laser, why? Because the light sensitive component, as I mentioned, the photosensitizer, can be applied topically. And what I mean by topically is when you have a cream, you put it on the skin, or it can be applied intravenously. So what this study has shown is using this portable laser, they can go into people's houses, treating the patient into their own home. And by going into their house, they can apply the cream having the compounds and then wait for this to accumulate into the body and then shine on light.
Oh.
Why is it clinically relevant? Because cancer treatments are always associated with cost.
Yes.
And usually some of the costs are associated like how long does the patient remain in the hospitals, right? And by providing such a therapy that is flexible and that address a need, especially in low and middle income country where most people cannot afford this therapy, that kind of reduce the cost by bringing the device into the patient's house and receiving the treatment at home. I think this is, for me, one of the advantage beside the clinical aspect, and the financial aspect as well is a very good one, yeah.
So we have talked, you have talked at length about the precision medicine, the therapies, some of the disease incidences, and how the different biomarkers or the discrepancies in biomarkers between different populations. So if you're putting all of this together in a big picture, what would you want to see as the next step for, to help communities that are most disproportionately affected by these cancers and by the cost of treatments?
Okay. So the first thing that I would like to do is to collaborate with people to have much more African biopsies, patients, just to establish like biobank of what are the profile per region, right? Whether it's Africa, Asia, South Latin America, because that's the first step. You want to know what's the profile of patients. So once we establish what the profile of patient, the next step is to develop drug. That's what they call antibody drug conjugates. Like it's when you have an antibody that are attached to a cytotoxic molecules. Okay? Maybe I have to explain a little bit what antibody drug conjugate is. So remember during the COVID pandemic, we had Omicron, we had Delta, I forgot again, whatever the antigen. So Omicron is a biomarker. That is specific to COVID. Delta is a biomarker. So a person having Omicron antigen will receive a vaccine anti-Omicron. Does it make sense?
Yes.
So usually people will get the DNA because the DNA will produce the protein, which is the antibody that will recognize Omicron. And when the antibody binds to Omicron, it activates the immune system to say, please guys, come and get rid of this one that is expressing Omicron. So using antibody drug conjugate, what we essentially do, as I mentioned, the first phase is to establish a biomarker. Because now what we do, just like vaccination, we develop antibody that recognize that specific biomarker.
Right.
An example is epidermal growth factor receptor as a biomarker. And what people have done is to develop antibody against epidermal growth factor receptor. So the prerequisite for biomarker to be clinically relevant, it has to be overexpressed. And in normal cells, it shouldn't be expressed or minimally expressed. An example will be in the normal cells, it will have 100 receptors over the cells, and by receptor I mean on the cell surface. And on the cancer cell, it can be 1 million of cells. So what you're actually doing is just maximizing accumulation of the drug in the cancer cell versus the normal cells. That's the first prerequisite. So once you have established this biomarker screening, that's the first step. Now is to develop therapy that addresses it. So what people have done so far clinically, they've used a lot of small molecules such as auristatin. So what they've done, they've conjugated to the antibody. So what they do now is they use the antibody as a vehicle to kind of deliver. And the easy assumption I like to take is like Uber Eats, right? When people get to, let's consider the person who is ordering as a cancer cells, right? The person put order, he has an address. Right? So the Uber Eats driver will be our antibodies. That will be carrying the cytotoxic molecule, which is the package that has to be delivered. Right? And when the Uber driver arrives in front of the person gate will be considered as the receptor. So the car, the vehicle and the Uber driver are what brings the drug. And once it gets into the drug, which will be the cell receptor, then it goes into the drug, you open the gate, the Uber driver goes into the house. Going into the house will be like going into the cells. And once he goes there, he releases the specific package, and that's the cytotoxic molecule that blew up the whole cells. Right? So that will be an analogy that can be taken of what antibody drug conjugates are. Recently, out of the many antibody conjugates, almost only 9 have been clinically approved. For the treatment of breast cancer, for example, there is only 1 that is approved for the treatment of triple negative breast cancer, which is one of the most aggressive ones. Right? So people have done research to develop this and conjugate it to the antibody.
And when you say it's the only one, is it just in the United States or globally?
Globally.
Okay.
Because you have to understand that in the breast cancer, there are many subtypes. There is what they call hormone dependence, because the receptor, there are hormones that are overexpressed. And triple negative breast cancer is negative for this hormone, estrogen, progesterones, and R2 receptor. And these patients, because they're negative for this receptor, they cannot benefit from drugs that are used clinically to target this receptor, such as tamoxifen, that is used for those who are positive for the hormones.
Right.
So when they're negative, they cannot benefit from that. So after chemotherapy and radiotherapy, unless they have a combination of radio and chemo, they had no therapeutic options. Recently, there is a TROP2 antibody drug conjugate that is targeting the TROP2 receptor that was clinically approved here at Harvard, and now it's being used in clinic. But the problem with that, these drugs are extremely expensive.
I can imagine.
One antibody drug conjugate for treatment can cost no less than 50,000
Wow.
per visit.
Per visit?
Per visit. So that's why the technology that people are mostly focused on, and like a group like us, we're trying to develop like something that is less cost. And since the cost of this antibody usually relate also to to biomanufacturing, because it costs a lot of money to produce it. So what people are trying to develop are methodology that enables the production of the antibody that has a low biomanufacturing cost, because that's where the most cost comes to.
Right.
And the technology, for example, I'm working on is trying to address it, where we kind of trying to demonstrate like how to produce it, so that it is cheaper and more accessible, because the aim for that is to have this type of facility so that it's more accessible. Because the problem with low and middle income countries right now that we have, and that's not only related to Africa, even Latin America and some Southeast Asia, the problem is because they are done biomanufacturing facilities comes from overseas, and that's an added cost now, because any drug coming into the country has to go to customs, and that also comes with a price. So yeah. This what I can say in a nutshell to respond to that.
Right, and then just to piggyback off your, you've mentioned low and middle income countries a lot. One of the things that comes to mind, because I'm talking to you, is language.
Yeah.
So you're from a French-speaking country.
Yeah.
Can you explain how their education system is in terms of what could be improved? Because much, from my understanding, a lot of the education is done in English.
Yeah.
So how does that affect countries that might not have fluency in English but need to learn the science, need to learn about the cures, need to engage with the research?
I mean, the way the French system, I mean, you're making a very important point here, because most of research is in English. And I got to realize it when I got into research. Like most of the publications, I barely find publication in French. So the difference between the French system and the English system, I can say from my experience, I mean from Gabon perspective, is the French system, first of all, is very broad. You have to study a lot of things, and sometimes that are not necessary. I had to study like geography and history, which is good to have like a good like overview of knowledge. But we don't specialize people from a very early age. Right now, what is versus the English system, where I see people from high school, they can already decide, I want to be an engineer, I want to be a doctor, I want to be a biotechnologist, and they will be streamlined to that. But in the French system, it's more broad. You touch everything, and then you specialize in universities. What has been done, and what should be done, I think, by most African governments now, is to kind of determine national priorities. For example, once the people determine national priorities, for example, in Gabon, like cancer is being one of them in most African countries, and now establish programs where people kind of specialize in the specific program that are of need. And I think in that aspect, that's what the Global Oncology University is, because there is a shortage of workforce in low and middle income countries, most middle income countries, in the healthcare sector in oncology related. This needs to be addressed in most French countries, because there is not much research in French country, and I think this is one of the aspects that need to be addressed, like from a very early potential. Now, when it comes to collaboration, that's why we need to intensify North-South, even collaboration between the Francophone and the Anglophone countries. and also kind of have bilingual programs. The former president Ali Bongo was trying to do that, where he was trying to now make Gabon like Rwanda. He wanted to introduce a bilingual to kind of address this type of shortage, where the Gabonese people in the administration will have to speak now French and English for this specific reasons. I mean, not for these specific reasons, for other political reasons, but it will have gained also from that, from the fact that research is done in English and most students are done.
Yeah. And one of the reasons also I asked is because having been, in conversations about research from whether it's here in the United States through the GHC or back home, is that some of the communities themselves, the people we're trying to treat, don't understand the terminology because it's in English.
Yeah.
So if we were to create a strategy for making cancer understandable in our communities, like if it was a dream, a big vision, how would that even be realized? From research, from academics to outreach in the communities. I'm just now drawing it out. I know you're more of a science guy. That might you're a nerd.
No. That's a very, I mean, like recently we've been having a lot of activity with the Young Global Health Catalyst going into many African countries, and that's actually addressed what you mentioned. We were in Cameroon, which is bilingual. There's a French side and the English side. We were in Nigeria and Kenya lately, and we had many students coming from different backgrounds, right? So we organized events where we first wanted to introduce people what precision medicine is, because it's not known of many people, right? Let's say, for example, if you have African governments, let's say, or any world governments, whether it's American governments, who want to invest in people going and specialize into a field. How will you give a scholarship to people to a special field that you don't know? I heard about biotechnology when I left my country. I didn't know what biotechnology was before. So we are organizing all these virtual conferences with world experts in like the US and Canada and all parts of the world, where we're trying to educate them on what precision medicine is, so that straight from high school, straight from first year university, they know there is an opportunity to specialize in it, because sometimes also people don't specialize in this field because they don't even know they exist, right? So we kind of go and trying to kind of evangelize people on that to what precision medicine is, so that they know what precision medicine is, and then they know where they can go if they want to acquire that type of knowledge. So that's what we are busy trying to do, because I think many of the resources are there, but they're not just used properly for the specific needs.
Yeah.
And what was the other part of the question?
The community engagement to understand these diseases, because even there is no, for example, in many cultures, there's no word for cancer.
Yeah.
So
okay, so for the community engagement, I think we need to have much more campaigns on that, and I will explain why. There is a region where, I can see where there is a lot of radioactivity, right? And there's a lot of radioactivity, or there's been oil spill. And suddenly people start developing a lot of cancer. And in this region, because they had birth defects, people used to think it's witchcraft. And I went back on the internet and started reading, and I realized myself it's because there are some radioactive material that were buried in this specific region.
where was that?
It was a region called Mwanda, in the south of my country, right, where there is like exploitation of manganese. And that manganese is radioactive. Yeah. And because people are living nearby these mining activities, these people are getting cancer because of that. But because in the village, as you just mentioned, people are not knowledgeable about cancer, they think it's witchcraft. They say like, oh, I've got a disease now, it's because of witchcraft. But what we have to do is also to speak to the authorities to make sure that safety measures are in place. This is the type of community engagement to make people understand that the diseases they are getting are related to the environment being not healthy, for them to kind of having a healthy lifestyle. We have to engage to tell them like cancer is not a curse, it's a disease. For example, in East Europe, in the Chernobyl, after the World War II, for example, soil were contaminated with radioactive materials. And what they did, they used phytoremediation to kind of use engineer plants to use the heavy metals to extract it from the ground and releasing oxygen, which is environmentally friendly. But believe it or not, people start developing cancer in many European countries, such as France, from dust from the Chernobyl site.
Wow.
So this dust contains these particles that are the heavy metals.
Right.
And unlike in organic compound, this heavy metal, they don't get metabolized in our body. They just accumulate and that becomes toxic. So these are the types of things that people are kind of not aware of, and then they need to be engaged. Because if I think of region where there is 90% covered by forest, it won't make sense for me why there is a cancer in this region, because people are supposed to eat healthy, and people need to get educated. People need to be educated on like pap smear test, on mammography, to take the consultation, because what I also observe is in a lot of countries, people don't get used to do medical examinations.
It's expensive for some.
Yeah, it's expensive for some. Yeah, I agree. I agree with that. But it's just to say that when people also have the opportunities, they have to do that, because sometimes they get diagnosed with late stage, and when they get diagnosed with late stage, they have less therapeutic option.
Absolutely. I mean, we could go on and on, Dr. Fleury. I know we've diverted from precision medicine, which was really the key topic today, but it's all intertwined, you know, for it to work, for it to be applicable in our in the communities it's intended for. So as we wrap up, what are some of the key takeaways for our audience in terms of precision medicine?
The key takeaways is, first of all, people need to, when they get diagnosed, to have access, whenever they have finance, to laboratories that identify specific cancer biomarkers. The second thing, once they identify it, they should seek access whenever possible, if they can afford the cost, to have precision medicine, because it has shown to have better therapeutic treatment. To governments who have not implemented a precision medicine program, this is a urge for you to establish biobanks, because there is a need to establish what's the patient's profile, because if there is no patient profile, we cannot treat the patients. So I will encourage a lot of governments to kind of develop this type of program, to train the workforce in this type of program, to make sure that not only we are able to diagnose, but we also be able to take care and manage this type of patients. That's what will be my key takeaways for precision medicine.
Well, first of all, thank you for taking us through 101 class on precision medicine.
Thank you.
It's exciting to learn, and also to not just to learn about the area or the subject, but also to hear the research you're part of, or the interventions that are in the pipeline, and hopefully we can get you back to the studio to give us some updates on how everything is going.
Definitely.
And then in terms of if we want to learn more about the research that you're a part of, how can people get to reach out to you?
I mean, people can reach out to me on LinkedIn. Usually, I have all my research that is published, right? Right now, I don't have a laboratory website yet. I try to provide all my literature on my LinkedIn profile, and you can also type my name on PubMed to have access to all of my research. So for now, that will be the main way people can reach out of me.
All right. So again, thank you so much for your time.
Thank you very much, Vivian, for hosting me.
Of course, it's a pleasure. And to our viewers, I hope you have learned about precision medicine and what Dr. Fleury has been a part of and why he does it. And, you know, you can reach out and learn more about his research projects. But for now, thank you for watching. Till next time.
Thank you very much.